When counseling patients and families with cytogenetic abnormalities, understanding the biological basis for the abnormality is important. This presentation is an introduction to the need for this understanding with a couple of examples. The objective is to discuss the significance of the mechanisms responsible for cytogenetic abnormalities in terms of counseling, the role of appropriate lab assays that would provide the most important pieces of information required for counseling, and the role of genetic counseling in ensuring comprehensive testing and management of cytogenetic abnormalities. Cytogenetic abnormalities can be broadly classified into numerical abnormalities and structural abnormalities. Numerical abnormalities involves gain or loss of whole chromosomes, and they can further be subdivided into sex chromosome aneuploidy and autosomal aneuploidy. So sex chromosome aneuploidy involves either gain or loss of a sex chromosome, and the autosomal aneuploidy involves usually gain of an autosomal chromosome. The most common sex chromosome aneuploidies are loss of one of the sex chromosomes, resulting in a karyotype of 45X, which is consistent with the clinical diagnosis of Turner syndrome. Another abnormality is 47XY and an additional copy of X. So there will be 47 chromosomes with the sex chromosome composition of XXY, which is consistent with the diagnosis of Klinefelter syndrome, and 47XY with an additional copy of the Y chromosome. So the karyotype would be a 47XYY. The most common autosomal aneuploidies are trisomy 13, trisomy 18, and trisomy 21, of which trisomy 21 is the most common, resulting in Down syndrome. Structural rearrangements can be broadly classified into balanced rearrangements and unbalanced rearrangements. The balanced rearrangements do not have loss or gain of any chromosomal material. They can be translocations, inversions, or insertions. Carriers of balanced rearrangements are phenotypically normal because there is no loss or gain of genetic material. However, they can give rise to gametes and offsprings that are unbalanced. Unbalanced rearrangements are either derivatives that are derived from translocations and recombinants that are derived usually from inversions. Unbalanced abnormalities can also be associated with markers and ring chromosomes. Shown on this slide are normal male and female karyotypes. Any deviation from this karyotype in terms of additional copy of a chromosome or a structural rearrangement of any of these chromosomes can be clinically significant. For this presentation, I will only be discussing some of the mechanisms involved with trisomy 21 and also the consequences of a kind of translocation known as Robertsonian translocations. Robertsonian translocations involve acrocentric chromosomes. Shown on the bottom of the slide are the 5 different acrocentric chromosomes in the human karyotype. That's chromosomes 13, 14, 15, 21, and 22. Acrocentric chromosomes do not have any clinically significant material on the short arm. So in Robertsonian translocations, the acrocentric chromosomes go through what is called whole arm translocations that result in loss of the short arm. Carriers of Robertsonian translocations are phenotypically normal because the short arm does not have clinically significant material. Hence, loss of the short arm is not clinically significant for the carrier. Chromosome number of carriers of the Robertsonian translocation is 45 because of the way the rearrangement occurs and the loss of it's not a reciprocal translocation where you have two of the long arms and two of the short arms resulting in two different chromosomes. There's entire loss of the short arm. So the number of chromosomes is only 45 in the carriers. Now, the carriers are at risk of having children with an unbalanced karyotype, and this imbalance can result in phenotypical abnormalities in the offspring, or these carriers can also have miscarriages because of the unbalanced constitution of the fetus. So shown here on the right are the various potential Robertsonian translocations that can happen. However, not all of them are encountered, partly because of the nature of the sequences on the short arm that does not allow for the whole arm translocations to occur in all combinations. And shown on this slide are two different Robertsonian translocations. On the left is a Robertsonian translocation between chromosomes 13 and 14. And as you can see, that's a whole arm translocation and with the loss of the short arm. And if you look at the count of the number of chromosomes, there will only be 45 chromosomes. And on the right is a Robertsonian translocation involving chromosomes 14 and 21. And again, there will be only 45 centromeres, and hence the chromosome number is 45. Shown here is how the Robertsonian translocations involving chromosome 21 in carriers will appear. On the left is a Robertsonian translocation involving chromosome 21 and 21, and on the right is from a carrier involving the Robertsonian translocation involving chromosomes 14 and 21. It's important to note that the chromosome number is 45. So if one was to see a cytogenetic report that shows a Robertsonian translocation, but only 45 chromosomes, you can conclude that this is the karyotype from a balanced carrier. So what happens when a Robertsonian translocation goes through segregation during gametogenesis? There are two different kinds of segregation that can occur. On the left is the alternate segregation and on the right is the adjacent. So when one goes to the alternate kind of segregation, you end up with either the normal copies of the two chromosomes involved or the Robertsonian rearrangement. But in either case, the fertilization with a normal gamete would result in a zygote, either which is completely normal, which is shown as B, or a karyotype, which will be like the parent, will have a Robertsonian translocation and a normal copy of the two chromosomes from the other parent. On the right-hand side, you can see how when the segregation is adjacent, one can end up with either a trisomy or a monosomy. So for instance, D will already have two copies. The gamete will already have two copies of one of the chromosomes involved in the Robertsonian translocation. So if that gamete is to fertilize with another gamete that is normal, that would end up with three copies of one of the chromosomes. So both the Ds will have trisomy for either one of the chromosomes involved, and both the Es will have monosomy for one of the chromosomes that's involved. Usually monosomies are lethal, so they do not come to term. However, trisomies can either result in a miscarriage, a recognized miscarriage, or phenotypically abnormal offspring. There are three different types of trisomy 21, and this is why it is important to know at the time of diagnosis and counseling what is the kind of trisomy 21 that one is dealing with. On the very left is what is called a standard trisomy 21, where there are three free chromosome 21s. In the middle is a trisomy 21 that has one normal copy of 21, and the two remaining copies of the trisomy 21 are in a Robertsonian translocation. And on the right-hand side panel is a trisomy 21 where you have two copies of the of 21, but also an additional copy of the 21, which is a Robertsonian translocation on chromosome 14. Now, if you look at the chromosome numbers, you can see that for a standard trisomy 21, there will be 47 chromosomes, whereas in the case of a Robertsonian translocation Down syndrome, trisomy 21, the number of chromosomes is 46. So if one was to see a report that shows a Robertsonian translocation along with 46 chromosomes as the chromosome number, then that would indicate that this is an abnormal karyotype and of clinical significance. 95% of cases of Down syndrome will have a karyotype with 47 chromosomes and 3 copies of free chromosome 21s. In about 4% of the cases, the Down syndrome will be the result of a Robertsonian translocation. 1/4 of these cases of the Robertsonian translocation that is associated with Down syndrome is familial, and 3/4 is what is called de novo, which means that if you look at the parents will have a normal karyotype. However, there have been families in which there have been repeated children who were born with a Robertsonian translocation associated Down syndrome, and in those cases it is thought that there is probably gonadal mosaicism of the Robertsonian translocation in the gonads of either the mother or the father, and that is the reason why there is a recurrence of the Down syndrome associated with Robertsonian translocation in those families. There's a critical region on chromosome 21 that is relevant for the phenotype of Down syndrome, and this is this involves bands Q22.2 and Q22.3. So anything that increases the copy number of that region can result in a phenotype of Down syndrome. So this could be a very small, subtle, intrachromosomal duplication of that region that could give rise to the phenotype of Down syndrome, or it could be due to a reciprocal translocation in a parent, as shown in this slide, where the mother was a carrier of a 1221 translocation that resulted in generating an abnormal chromosome 12 that had a part of the critical region of chromosome 21 on the short arm of the abnormal chromosome 12, resulting in a phenotype of Down syndrome. So why is it important to know what is the kind of karyotype that is associated with trisomy 21 in a given family? So if you look at this family, you can see how all the individuals, all the offsprings of this couple had trisomy 21, and it turned out that this is because the mother was a carrier of a 2121 Robertsonian translocation. So when you have a 2121 Robertsonian translocation, all the all the gametes that are formed, or 50% of the gametes that are formed, will already have two copies of 21. The gametes that do not have chromosome 21 may not be fertilized because they may not be viable or may be eliminated early in the gestation. So when you have all, if all the viable gametes have a 21-21 Robertsonian translocation, that means it's 100% recurrence if you have a carrier who is a 21-21 Robertsonian translocation. So if you look at a patient and you see that the patient is a 21-21 translocation associated Down syndrome, one has to look at the parent to see if which one of the parent is a carrier. And once you have shown that one of the parent is a carrier, then the risk of recurrence is 100%. If, however, one of the chromosomes involved is a chromosome 14, then it's not 100%, it is likely around 50% because you can still have, the way the segregation happens, not all the gametes that are formed will already have two copies, will already have two copies of the chromosome 21. So it's very important to understand what is the karyotype in a patient of Down syndrome, because if it is a Robertsonian related trisomy 21, the risk is much higher than if it is a standard free-floating trisomy 21. And here is yet another case where a couple had 13 pregnancies. 4 of the children were proven or presumed to have had Down syndrome, and there were 9 miscarriages. And the 9 miscarriages were likely because of an unbalanced karyotype with 3 copies of chromosome 21. Not all trisomy 21s result in miscarriages, and that is why in such a family you will see both miscarriages as well as children who are born with Down syndrome. If you look at the frequency of Robertsonian translocations, if you look at the literature, there is a little bit of a bias there because most of those cases are cases where there is a phenotypically abnormal offspring, whereas on the right you will see how there is the unbiased ascertainment. Again, if you look here, you will see that where chromosome 21 is involved, there is a greater preponderance or prevalence. For instance, the 14-21 Robertsonian translocation, it's about 20%, it's about 30%. For the 21-21 Robertsonian translocation, it's about 17%. So the 30 and the 17%, the 14-21 and the 21-21, the numbers are higher, likely because they are ascertained due to an offspring that had Down syndrome. Now coming to the kind of lab technique that is involved in detecting trisomy 21. Some of these techniques will not give you all the information that is adequate for providing the appropriate recurrence risk. Some of these techniques are used because of logistical reasons. For example, fluorescence in situ hybridization is a very rapid procedure and provides critical information in a pregnancy that needs that information as quickly as possible. However, and also non-invasive prenatal testing is it's a very popular technique now, which uses molecular techniques, but all fluorescence in situ hybridization and non-invasive prenatal testing, all it tells you is that there are 3 copies of chromosome 21, if trisomy 21 is present. It will not tell you what is the mechanism behind it. The same goes for microarray. It will only tell you that there is an increased copy number of chromosome 21. It will not tell you whether it is because of free-floating trisomy 21 or because of a Robertsonian translocation. That information can be attained only by performing G-banded cytogenetics, because that will clearly show you if it is a free-floating trisomy 21 or a Robertsonian translocation. So again, if one was to counsel a patient of a family that has a patient with trisomy 21, and all they tell you is that the patient has trisomy 21, and you do not have any lab results to know how the trisomy 21 was detected, the counseling will not be adequate enough, because you do not know what the recurrence risk is going to be. So it's very important to make sure that you have the G-banded results for these cases, so that the information regarding recurrence risk that is provided is appropriate. So what is the risk of having a child with aneuploidy? As you can see on this slide, if the mother is the carrier of a Robertsonian translocation, the possibility of having a child with an unbalanced karyotype is greater than if the father is the carrier. So this is something to be taken in consideration when counseling. If you see that the mother is the carrier of a translocation, then the numbers will be greater than if it's the father. If it's the father, it's very small compared to if the mother is the carrier. Two of the chromosomes involved that can be involved in Robertsonian translocations are chromosomes 14 and 15. And both these chromosomes are known to have regions of imprinting, that as a result of which there are UPD, uniparental disomy related conditions that can show up. And the mechanism by which it happens is through either what is called trisomy rescue or monosomy rescue. Shown here is the mechanism of trisomy rescue. As you can see, there are two copies of trisomy 15 that is derived from the parent who's the carrier of the Robertsonian translocation, and one chromosome 15 from the other parent. So now you have three copies of chromosome 15, which is trisomy 15. When the zygote goes through the process of trisomy rescue, it can lose either one of the chromosome 15s. If it happens to lose the one that is derived from the normal parent, the zygote results in having two copies of chromosome 15 that is from the same parent. And because of the imprinting, concept of imprinting related to chromosome 15, that the child that is born from that fetus will have the UPD syndrome that is associated with that chromosome 15, depending on whether the carrier was the mother or the father. And how does what are the ways in which potential trisomy rescue is detected? It's often detected during prenatal diagnosis. During when chorionic villus sampling or non-invasive prenatal testing is performed, and if these studies show trisomy, and when you go on and do a follow-up of amnio, but that shows a disomy, then one knows that there is trisomy rescue that has occurred. And at that stage, one has to determine if the trisomy rescue resulted in uniparental disomy or not. And this can be looking at polymorphic variants between the fetus and the parents, to see whether the two copies that are present are from the two different parents or from the same parent. So it's during prenatal diagnosis that one will encounter this kind of a situation where you know that there's a possibility that there was a trisomy rescue. And when a chromosome that is involved, which is known to be involved with uniparental disomy, is involved in in such a situation, then the additional studies will have to be performed. So these are all things that comes under during genetic counseling, and it's important to educate the family, to explain to them these very sophisticated biological mechanisms and why this testing would be beneficial to them. So if chromosome 13 is involved, the risk is of having an offspring with trisomy 13 or Patau syndrome. If it is chromosome 14, you can have trisomy 14, but usually they do not come to term. There is the risk of uniparental disomy, so that is something to be considered. And if it is chromosome 15, once again, there is the risk of uniparental disomy of chromosome 15 that has to be taken into consideration. And if it's a chromosome 21 that is involved in the Robertsonian translocation, then the risk is mostly of trisomy 21. There is approximately a 7-fold excess of Robertsonian heterozygotes among couples who are infertile. Among male infertility, there is a 10-fold excess of Robertsonian carriers in men presenting with infertility due to oligospermia, especially in cases of severe oligospermia. So this is a mechanism, this is one of the reasons why the Robertsonian translocations are not transmitted from a male carrier compared to female carriers. So to recap, more than one mechanism is involved in generating trisomy 21. Use of the appropriate technique that is most informative in understanding the mechanism is essential for estimating the recurrence risk. In certain cases, parental studies may be essential in determining recurrence risk. Family history and pedigree may also provide useful information. Uniparental disomy can occur in offsprings of carriers of certain Robertsonian translocations, that is, those involving chromosomes 14 and 15. Genetic counseling of cytogenetic abnormalities involves identifying the genetic basis of the abnormality. This can sometimes be done by looking at the family history. It can also be done by using the appropriate testing to see if it is a translocation or what is the biological or the cytogenetic mechanism that's involved. Counseling will also include providing the information required for the family to make informed decision. For example, in the case of trisomy 21, if it is a 21-21 Robertsonian translocation, and if one of the parents is a carrier, then the patient has to be counseled that there's a 100% chance that every offspring will be affected with trisomy, with Down syndrome. The genetic counseling component will also involve aid in facilitating testing, that is family members who may be carriers, and also appropriate prenatal testing. The various kinds of tests available for prenatal testing, that is fluorescence in situ hybridization, non-invasive prenatal testing, or conventional G-banding techniques. So all this is the kind of information that can be provided to the patient and the family during the process of genetic counseling. If you have any questions, comments, or suggestions, please email them to me at the email address shown on this slide. Thank you.